wonderful. Dr. Amrou Sarraj is the principal investigator of SELECT and SELECT-2 trials. The SELECT-2 research study was conducted across 31 comprehensive stroke centers and tertiary hospitals in the US, Canada, Europe, Australia, and New Zealand, with UH as the coordinating center. In 2024, Dr. Sarraj also received the 2024 Top Clinical Research Achievement Award by the Clinical Research Forum, as Dr. Simon pointed out. This makes UH the only hospital system to have 2 honorees acknowledged in 2024 by a national consortium for the 10 most significant clinical advancements impacting the health and wellness of humanity. So today, Dr. Sarraj will be talking about recent developments in large core thrombectomy, the SELECT-2 trial, and subanalyses.
Thank you so much for the kind intro. I think I should say good morning, everybody. It's evening here, but thank you, Dr. Simon, for having me, and thank you, Ms. Fritz, for accommodating. Pleasure to join you from here. I'm here to present at the World Stroke Organization conference. So that's how I happen to be in Abu Dhabi. We'll share what we have done in the SELECT-2 trial, and we'll share few future frontiers on what can be coming. So I'll start with the aforementioned SELECT-2 trial, which was a randomized phase 3 trial that, as was mentioned, conducted in North America, Europe, Australia, and New Zealand. And we used covariate adaptive randomization to balance the baseline characteristics. You don't want sicker patients, those who are older with larger strokes, to be in one group versus the other. So that was the basis. This is a diagram of how patients were enrolled. Everybody got the baseline CAT scan, and those patients all have large vessel occlusion in the internal carotid artery or in the middle cerebral artery first segment, the MCA. M1, all of them got a CAT scan. The difference here and the basis of the trial is we are enrolling patients with large strokes, those who were not being treated in the past under the concept of too much tissue damage to treat, less likely to benefit, and too much risk of reperfusing the tissue with high risk of hemorrhagic transformation. So the risk-benefit ratio is not in favor of the patients, or that was the thought process. As you see on the CAT scan and the principle of looking at imaging, that's what we teach the residents and the fellows, that you look for asymmetry. You look to the left, you look to the right. Hopefully the resolution is good for you to see that the left, there is a large hypodensity in the left MCA. We didn't do just simple imaging with the CTA, but we also did advanced imaging with perfusion imaging. You see here the software that we use, the Rapid software, which takes the perfusion and calculate the volume of the infarcted tissue and the tissue at risk. And the pink area here is the infarcted tissue, and you see 92 cc's. This is a large stroke. Anything more than 70 cc's was considered a large stroke prior to SELECT-2 and a couple of large core trials. And those patients were not treated. And we did MRI in some cases, and you see the pink area is the infarct. So those patients prior to these to SELECT-2 and other large core trials were not being treated, not part of the guidelines. Guidelines were calling for randomization. And what we did, actually, we did this pretty methodologically. We started with SELECT, which was a phase 2 non-randomized trials, and we found signal of benefit with reasonable safety profile. We proceeded based on it with SELECT-2. Those were the sites, mostly North America, but about 1/3 of the sites were in Europe and Australia and New Zealand. This is the enrollment chart, and putting this bring a lot of good memories. This is where we enrolled. We enrolled about over 3 years, and the plan was to enroll 560 patients. But after 3 years, the DSMB asked us to stop for reaching efficacy, and then it became non-ethical to randomize patients. But what I want to bring your attention to, if you remember, this is around when the trial was just starting. This is when COVID hit, and there was a lot of challenging on how to enroll, and IRBs asking the investigators to close the trial, and hard to get patients and their families or their families to consent. And what you see that we actually moved pretty good. That was because of a lot of work from myself and the co-investigators instituting remote consenting, increasing the sites numbers, and working with IRBs that at the end of the day, this is in the best interest of the patient. So we moved very well, and we were stopped around 3 years. And pride myself that with the fact that this is not the usual that you see where the principal investigator resides. Most of the patients are enrolled. Actually, we have 2/3 of the sites enrolling 10 patients or more. Almost everybody contributed. Of course, I'm going to give UH as probes. You see here, I came to UH around August of 21, and the trial was stopped in September of 22. So within less than a year, we enrolled 21 patients. And this is one of the strengths of our system, having a lot of hospitals to feed and having people who can identify and enroll patients. So we screened about 1,000 patients to enroll 352 patients. 174 went to medical management, 178 went to thrombectomy, 2 crossovers, which is pretty good number. Only 4 patients lost follow-up, which is also a good number. So a great effort from all of the site investigators and teams. And the intention to treat analysis is the basis of this analysis. So this is the outcomes, and we measure the outcome in stroke based on the modified Rankin scale, which is functionality at 90 days and at 1 year. 0, 1, and 2, which is to the left side of this column, considered good, 0 being normal, 6 on the other extreme being dead, 5, you may think of somebody who is needing 24/7 nursing assistant, nursing home, or bedridden. 4, somebody who is unable to walk, needing significant assistance with their daily living activities. 3, able to walk with a cane. 0, 1, and 2 being pretty much independent with some residual deficit. So these are large strokes. You're not going to see 60-70% of the patients having, functional independence and doing well as we wish they are, because at baseline they have severe disease. And the thought when I started talking about this, that they would not benefit, they will not do well with thrombectomy, there will be high risk. So this is the medical management. As expected, you have about 80% of the patients ending up with very severe disability, modified Rankin of 4, 5, and 6. And this is thrombectomy. And you see a shift, and that's how we measure the ordinal analysis, shift towards better outcomes with thrombectomy as compared to medical management. And that translated to 60% likelihood of superiority of patients being treated with thrombectomy to at least improve by 1 point on the modified Rankin scale as compared to medical management, and 1.5 the likelihood of achieving better outcome with thrombectomy, and the number needed to treat for that was 5. You treat, and this is a huge win, you treat 5 patients with large course strokes for 1 of them to improve. And you may say, well, I mean, you told me that patients are less likely to achieve a functional independence or walk independently, but what happened in these cases? Thrombectomy tripled the number of patients who achieved functional independence. Number needed to treat was 7. and doubled the number of patients who were at least able to walk independently. This is a patient coming with a very severe stroke, plegic on one side, unable to talk, with a large stroke at baseline, and think of 100 cc's, half of their hemisphere being thought to be infarcted, that ends up walking independently at 90 days. Just to put things into context, this is a significant development that resulted in a lot of patients being treated and going back to their families and to the society independently. What about safety? The risk of symptomatic hemorrhage was actually pretty low. Just think, I mean, there was a lot of hemorrhages, but not symptomatic. Symptomatic hemorrhage, meaning worsening of the patients because of the hemorrhage. And we actually have only 2 patients in medical management who had symptomatic hemorrhage, one in thrombectomy. Mortality was reduced with thrombectomy, but did not reach statistical significance. So why there isn't a lot of symptomatic hemorrhages? Because these patients come at baseline with very large strokes. It takes a lot to make them worse, so to speak, and apparently we can make them better. The paper was published in the New England Journal of Medicine and presented simultaneously at the International Stroke Conference in February of 2023, I'm sorry. So we moved from there to what happened to these patients on the long term. Can they continue to improve? Can they go back when they go back to the family and to the society, and when the stroke sits with them? How do they do, not just functionally? How do they do from a psychological standpoint, productivity standpoint? What did they and their family think at 1 year? So to our as expected, but to our happiness, so to speak, that the thrombectomy continued to do better. At 1 year, there were 20% of the patients that continued to have improvement, at least by 1 point, from 90 days to 1 year. The number need to treat was 6, and the outcomes were pretty much the same. This paper was published in The Lancet a year after and presented simultaneously at the International Stroke Conference. And I told you about the quality of life. What did they think? What did they and their family think? And that's pretty important, because you can keep somebody alive. You can say, well, I mean, they are able to walk, or some of them are, but did they think that that was in their best interest? And all of the quality measured, whether it's depression, whether it's cognition, whether it's other metrics in terms of functionality, all of them, whether either were less or more in favor of thrombectomy. So patients and their families said that, so their surrogates, that they would do this again if it were to happen, if they would have given the choice again. And then the third important concept here is, how large is large, and how can we define large? Is it infinite, or are there limits? I mean, there is no question, as the stroke sizes increase, patients are less likely to do as well as those who have smaller strokes. But that's the wrong way of thinking of things. That a lot of people say, well, he is not going to do as well as the patient who has 50 cc's or who has a smaller stroke. But that's not what you are measuring. You are measuring, are they going to do better than those who will not receive the procedure, better than those who will not receive the intervention? Of course, as disease is more severe, the likelihood of achieving the desired outcome would not be as well, but is it better than medical management? And that's what you want to know before offering the intervention, whether the family is interested in it or not. This is where prognostication come rather than selection and saying, I will not treat these patients. So we looked at all of those in different imaging modalities, and again, thrombectomy continued to be better than medical management without heterogeneity even with patients with very large cores, more than 150 cc's. About a year later, there was a French trial that came and looked at the same concept with more than 150 cc's. They had a large number of patients, and thrombectomy was better than medical management. The likelihood of achieving the MRS of 0 to 2 and 0 to 3 decreased, which is again prognostication and discussion with the family, but it continued to be safe and better than medical management. This paper was published in JAMA at the same time that the 1-year outcomes were published at the International Stroke Conference and presented simultaneously. So another point that was covered in large core from the SELECT-2 trial. And then the other component that I mentioned to you that we have a large system at UH is what about where the patient present? What if they do not present to a thrombectomy center? They present, like most of the patients, they present where we do not have advanced procedures offered. I mean, we published a paper on this a few years ago. That only 1/3 of Americans have access to a thrombectomy center within 1 hour. So most of the patients will not present to a thrombectomy center. Do they still benefit from the procedure? Can we transfer them and proceed with the intervention for them to have a good outcome? And this is stratifying patients between those who presented directly and those who were transferred. And you see that the odds were in favor of thrombectomy with a shift towards better outcome. There is no question that the treatment effect was larger in those who presented directly, but was maintained in those who, and this is 1.5. I mean, this is significant, so to speak. And as you see, the reality is most of the patients present outside. So how do we work on that? We improve transfers protocol. We put advanced images and AI, which is exactly what we are doing here at UH. We're rolling out the same software that we used in the trial in all of our Northeast Ohio centers to identify these patients quickly and transfer them to offer them the procedure and have better outcomes, because time remains brain, and the longer the transfer took, the less likely the patients achieve the desired outcome. So there was no heterogeneity in the treatment effect when you looked at transfer versus direct, and this paper was published at the same conference in JAMA Neurology and presented simultaneously. These are the major sub-analyses. We planned in advance that we will address every subcategory. We will address any concern that physicians or guidelines going to come up with. Years of planning is coming fruitful. There was a paper that looked exactly at the hemorrhage, because physicians continue to fear the risk of hemorrhage. There is a paper that looked at anticoagulation and can you offer thrombectomy. And this is Dr. Pujara, my research team lead in Annals of Neurology, and showed safety in these patients. And there are other 6 papers that are accepted and will be published in the next few months. I will be here presented the cost effectiveness, which is a major component of, you are showing that a procedure is effective clinically, but how can you roll it into systems of care? Do the systems of care benefit from this? Is it cost effective? And I'll be presenting this at this conference, and we're looking at other things based on sex, based on hypodensity. So by the time of the next stroke conference, we will have exceeded 20 papers from the SELECT-2 trial. So what are the next frontiers? Do we stop here, or is there more to achieve? One of the major hurdles was the stroke size that I think we brought down pretty good with our colleagues from China and Japan, and we're in the process of pulling the data in Germany together to address every concept of the large core. The other major hurdle is time. You hear about patients presenting pretty late, beyond 24 hours. And this is an issue of disparities. Those who don't have access, those who are elderly, who live alone, and the stroke was not recognized early, minorities, they can present late, and a lot of times they don't even have the opportunity to be offered to transfer to a stroke center that can offer advanced treatments. It's too late. Why would I even make the phone call? So we looked at that in a like the same methodological approach that we have in the SELECT-2 trial. We started with SELECT with a non-randomized phase, and we moved to SELECT-2. Here we did a retrospective cohort, the non-randomized phase, if you may, with people across the globe, and published this about a year and a half ago. That showed safety and benefit, and a significant number of patients presenting actually beyond 24 hours. So we continue to have this problem, and we are, I think, pretty in pretty good shape to start a randomized trial with federal funding that's going to be larger than the SELECT-2 trial that address this concept. And we are in the era of artificial intelligence, and we are in the while we want every single patient to be treated, we want every single patient to have the opportunity to be considered for thrombectomy. There is reality of identifying tissue that may alarm us to the risk of bleeding. One of my mentor and one of my colleagues, Dr. Bruce Campbell, in Melbourne, Australia, with his team, looked at the severity of the hypodensity and measuring it on the CT with the Hounsfield unit. And they identified a certain threshold that can identify patients who have higher risk of a bleeding. This is one of the sub-analyses papers that will come, and we're working on an AI program that can, provide this hypodensity measurement to identify patients who may not benefit from the procedure and may not be transferred for the purpose of the procedure. And you see here in red the degree of the hypodensity as measured, and this is manual at this point. What we look for is to do it with an AI program, so it's available for everybody. Then the other point is what I mentioned to you, that 80% of the patients with medical management don't do well. While thrombectomy was better, it remains that about 60% of the patients don't do well. I would like for these numbers to improve. We have better understanding now of concept of imaging, understanding of treatment modifiers and prognosticators, and we can enhance the good outcomes that we are having by introducing ways of reducing the cerebral edema, neuroprotection, and reducing neurotoxicity to improve this number from 40% of the patients being walking independently to probably 60 or 70%. This is where adjunctive therapy, you are opening the blood vessel, you're improving the patients clearly as compared to medical management. How can you support this effective procedure to capitalize and optimize the patient's outcomes? This is earlier stages, so to speak, and this is where you need to work with pharma and identify the right agent. We work with a French company on a possibility, but unfortunately this didn't pan out in another trial with another intervention. So this is again translational research. It's another territory that you have to identify the right agent, the agent that can be delivered, and the agent that can improve the outcomes. We'll see how that goes. As I mentioned, this was in the heart of COVID. I might look as the face of this, but this was a great effort from people across the globe I visited almost every single site. I didn't go as far as Australia. I'll do and select late. But really, people were greatly supportive, very, very, very helpful. The last thing that I want to say is, you may think that this is a huge multi-million. It is multi-million dollars, but it's not as large as the usual. It's more pragmatic trial. You may think that there is a huge team behind this. It's actually me and my two people, Dr. Pujara, who I mentioned earlier, and Faris, who left us to go to residency, who did most of the work, of course, supported by the two institutions that I was at, but a lot of work from these two people to get where we are today. Thank you so much. Happy to answer any questions.
Thank you very much, Dr. Sarraj.